Pedodontics LEC 11 Dr. Kamal Ibrahim. Periodontal diseases in children. Periodontitis, an inflammatory disease of the gingiva and deeper tissues of the periodontium, is characterized by pocket formation and destruction of the supporting alveolar bone. Bone loss in children can be detected in bite wing radiographs by comparing the height of the alveolar bone to the cementonenamel junction. Distances between 2 and 3 mm can be defined as questionable bone loss, and distances greater than 3 mm indicate definite bone loss. Periodontal probing for attachment loss and bite wing radiography are often used to clinically confirm the diagnosis. Bone loss is usually between the primary first and second molars. 1. Early onset periodontitis, EOP. This term used as a generic term to describe a heterogeneous group of periodontal disease occurring in young individuals who are otherwise healthy. EOP can be viewed as three categories of periodontitis that may have overlapping etiologies in clinical presentations. A localized form, localized juvenile periodontitis, LJP. B. A generalized form, generalized juvenile periodontitis, GJPI. C. A pre-pubertal category that is thought to have both localized and generalized forms, localized and generalized pre-pubertal periodontitis. A. Localized early onset periodontitis. Localized juvenile periodontitis occurs in otherwise healthy children and adolescents without clinical evidence of systemic disease. It is characterized by the rapid and severe loss of alveolar bone around more than one permanent tooth, usually the first molars and incisors. It appears self-limiting, and retrospective data obtained from LJP patients suggest that bone loss around the primary teeth can be an early finding in this disease. Clinically, patients have little or no tissue inflammation and very little supragingival dental plaque or calculus. Progression of bone loss is 3 to 4 times faster than in adult periodontitis. B. Generalized early onset periodontitis. Generalized juvenile periodontitis. The generalized form of EOP occurs at or around puberty in older juveniles and young adults. It often affects the entire periodontium of the dentition. Treatment of juvenile periodontitis. Successful treatment depends on early diagnosis, use of antibiotics against the infecting microorganisms, and provision of an infection-free environment for healing. Treatment of EOP. Both the localized and generalized types include surgery and the use of tetracyclines, sometimes in combination with metronidazole. 2. Pre-pubertal periodontitis. Pre-pubertal periodontitis of the primary dentition can occur in a localized form but usually is seen in the generalized form. A. Localized pre-pubertal periodontitis, LPP, is localized attachment loss and alveolar bone loss only in the primary dentition in an otherwise healthy child. The exact time of onset is unknown, but it appears to arise around or before 4 years of age, when the bone loss is usually seen on radiographs around the primary molars and/or incisors. Abnormal probing depths with minor gingival inflammation, rapid bone loss, and minimal to varying amounts of plaque have been demonstrated at the affected sites of the child's dentition. Abnormalities in host defenses, example, leukocyte hemotaxis, extensive proximal caries facilitating plaque retention and bone loss, and a family history of periodontitis have been associated with LPP in children. As the disease progresses, the child's periodontium shows signs of gingival inflammation with gingival clefts and localized ulceration of the gingival margin. B. Generalized prepubertal periodontitis, GPP, occurred during or soon after the eruption of the primary teeth. It results in severe gingival inflammation and generalized attachment loss, tooth mobility, and rapid alveolar bone loss with premature exfoliation of the teeth. Testing may reveal a high prevalence of leukocyte adherence abnormalities and an impaired host response against bacterial infections. Treatment of LPP or GPP depends on early diagnosis, dental curettage, root planing, prophylaxis, oral hygiene instruction, restoration of decayed teeth, removal of the primary teeth that have lost bony support, and more frequent recalls. Use of antimicrobial rinses, chlorhexidine, and therapy with broad-spectrum antibiotics are effective in eliminating the periodontal pathogens. Treatment of GPP is less successful overall and sometimes requires extraction of all primary teeth. 3. Papilloma syndrome. Precocious periodontitis. It is a rare disease. Etiology is unknown, characterized by premature loss of primary and permanent dentition, along with hyperkeratosis of the palm, sole, elbows, and knees. Alveolar bone loss is severe in precocious periodontitis so that primary teeth are lost by 3 to 5 years of age. Patient with this syndrome showed depressed PMN, chemotactic and phagocytic response. Treatment: conventional therapy with oral hygiene instruction, professional cleaning, and frequent recalls and antibiotic therapy have failed to prevent tooth loss in papilloma syndromic patient. Identification of specific pathogens, specific antibiotic therapy against these organisms, and full mouth extractions early enough to prevent infection of the unerupted teeth. Gingival recession. It is often observed in children. Several factors predispose patients to gingival recession. These factors include presence of a narrow band of attached or keratinized gingiva, alveolar bony dehiscence, toothbrush trauma, tooth prominence, impinging frenum attachment, soft tissue impingement by opposing occlusion, orthodontic tooth movement, use of impression techniques including subgingival tissue retraction, oral habits, periodontitis, and pseudorecession, extrusion of teeth. Recession is dealt with conservatively by elimination of the stimulus, if possible, while excellent oral hygiene is maintained in the affected areas. If the recession of the affected area remains unchanged, non-progressive, or improves, less recession observed over time, continued periodic monitoring is recommended. If the recession has progressed after a 4 to 8 week period of observation, other periodontal procedures may be required based on the identified predisposing factor. Self-mutilation. Occasionally children purposely traumatize their oral structures. Self-mutilation probably occurs more frequently than is realized because relatively few children will admit to the act unless they are observed practicing it. Therefore, the self-inflicted lesions may be incorrectly diagnosed. Dentists should be aware of the possibility of this condition and should approach the problem in the same manner as they do thumb sucking. An attempt should be made to determine the cause. If it is found to be the result of local dental factors, it can be corrected. However, in the majority of children an emotional problem is involved, and the family must be directed to competent counseling services. Tension and conflicts in the home can cause self-mutilation in young patients. Traumatic gingival recession in infants resulting from a dummy, pacifier, sucking habit. A segment of the plastic shield is embraced by the infant's lower lip, so that the inner surface of the shield bears against the labial aspect of the incisors and the gingival tissues. If the shield is held in this position, the edge of the shield moves with an abrasive action during sucking, which leads to gingival injury, recession, and loss of alveolar bone. Extrinsic stains and deposits on teeth. Previous work regarding the staining of children's teeth has been related primarily to studies of orange and green stain of the extrinsic type. It has been generally accepted that the stain has a microbial origin, although some reports have indicated that oral iron preparations or other medications may be responsible for an additional type of extrinsic staining. Staining is generally believed to be caused by extrinsic agents, which can be readily removed from the surface of the teeth with an abrasive material. The agents that are responsible for staining are deposited in enamel defects or become attached to the enamel without bringing about a change in its surface. Pigmentation, in contrast to extrinsic staining, is associated with an active chemical change in the tooth structure, and the resultant pigment cannot be removed without alteration of the tooth structure. 1. Green stain. The cause of green stain, which is most often seen on the teeth of young persons, is unknown, although it is believed to be the result of the action of chromogenic bacteria on the enamel cuticle. The color of the stain varies from dark green to light yellowish green. The deposit is seen most often in the gingival third of the labial surface of the maxillary anterior teeth. The stain collects more readily on the labial surface of the maxillary anterior teeth in mouth breathers. It tends to recur even after careful and complete removal. The enamel beneath the stain may be roughened or may have undergone initial demineralization. The roughening of the surface is believed to be related to the frequency of recurrence of the stain. 2. Orange stain. The cause of orange stain is likewise unknown. Orange stain occurs less frequently and is more easily removed than green stain. The stain is most often seen in the gingival third of the tooth and is associated with poor oral hygiene. 3. Black stain. A black stain occasionally develops on the primary or permanent teeth of children, but it is much less common than the orange or green type. The stain may be seen as a line following the gingival contour, or it may be apparent in a more generalized pattern on the clinical crown, particularly if there are roughened or pitted areas. The black type of stain is difficult to remove, especially if it collects in pitted areas. Many children who have black stain are relatively free from dental caries. Removal of extrinsic stains. Extrinsic stains can be removed by polishing with a rubber cup and flour pumice. If the stain is resistant and difficult to remove, the excess water should be blotted from the pumice and the teeth should be dried before the polishing procedure is performed. Because stains are most often seen in a mouth in which there is poor oral hygiene, improving the oral hygiene will minimize the recurrence of the stain. Pigmentation caused by Stannous fluoride application. During the first clinical trials involving the topical application of an 8% Stannous fluoride solution, certain areas of the tooth became discolored. A characteristic pigmentation of both carious and precarious lesions has been found to be associated with exposure to Stannous fluoride. Calculus. It is not often seen in preschool children, and even in children of grade school age it occurs with much lower frequency than in adult patients. A low caries incidence is related to high calculus incidence. Children with mental retardation often have accumulations of calculus on their teeth. This accumulation may be related to abnormal muscular function, a soft diet, poor oral hygiene, and stagnation of saliva. Supragingival deposits of calculus occur most frequently and in greater quantity on the buccal surfaces of the maxillary molars and the lingual surfaces of the mandibular anterior teeth. These areas are near the openings of the major salivary glands. Local factors are unquestionably important in the initiation of calculus formation.